Yeah. So the paradox of medical management. So as we all know that it's apoptosis which is causing the visual loss in glaucoma, and as of now we know that IOP increase is not the only factor which causes apoptosis, but we have a host of other factors like oxidative stress, the deposits of insoluble peptides, inflammation, immunity loss, the mitochondria destabilization, the vascular dysregulation, and many others which actually cause apoptosis. And to stop apoptosis, basically, we need to have glaucoma neuroprotective agents. So the neurotropic support that is required, the stem cell therapy, the bioenergetic support, the genetic therapy, and of course lowering of IOP, which we have been doing so far. So why I called it the paradox of medical management in glaucoma, because it is really the best of times, because we have a host of glaucoma medications. Almost every company under the sun has a glaucoma medication, and not one, they have a cafeteria choice of medical management of glaucoma medications. But it is also the worst of times, like Charles Dickens said in his Tale of Two Cities, because we are not actually targeting what we want to do. All of them lower intraocular pressure, but none of them actually can stop apoptosis. So here is the message to the industry that the next research maybe we could actually target neurotropic drugs, basically, because they are the ones which are going to stop apoptosis. And being in one of the centers which conducts phase 3 trials, I feel an urgent need for conducting trials on neuroprotective agents instead of just IOP lowering. So if you look at that glaucoma medication timeline, you would see that pilocarpine was invented as early as 1875, and following that we had Latanoprost somewhere in 1996, and then till date, say about till 2014, nothing much came in except different brands of Latanoprost, Travoprost, and Bimatoprost. And then in 2019 we had Tafloprost, which the West had it much earlier, but we had Tafloprost just lately. What we had in the last decade are the fixed dose combinations, which were a revelation, like 2 drugs in 1 container, which made things much simpler for the patient. And we have, as you all know, the timolol and the prostaglandin analogs, which came in the early 90s. And then, of course, we have the brimonidine and timolol with dorzolamide and timolol. And finally, we have the brinzolamide brimonidine combinations. So let us have a look at the preservatives which actually marred the glaucoma management. Benzyl cholium chloride, as we all know, we thought that it was essential for drug penetration, but it has been proved that no, it is not essential, because bark actually not only does it cause an ocular surface disbalance, but we also have problems with the conjunctiva when we are going in for a glaucoma surgery if the patient is on bark for a long time. So now we have medications which are free from bark, and maybe reducing patients' overall preservative load may improve adherence and quality of life, and of course the patient-doctor relationship, because every time your patient comes and says that I cannot apply the drop, I have a red eye or itching, it becomes very difficult and cumbersome for the treating physician. So why new drugs? We need new drugs, as I said in my start of the talk, that neural damage irreversible drugs, that's neuroprotective agents. Again, patients with asthma, bradycardia, and allergy to certain drugs cannot use many of these drugs, so we need drugs beyond that. And maybe we need drugs without preservatives, and we need drugs with new delivery systems. So the RHO-associated kinase, that the ROCK inhibitors that we have them in the market at the moment, but I suppose we need a lot more research on those drugs to be able to actually prescribe them on a regular basis. They are MAO inhibition of Rio kinase, which causes increase in outflow and lowering of intraocular pressure again there. And ripasudyl hydrochloride is one of the drugs which is marketed in Japan but is in phase 3 trial. We are expecting the results anytime. And then we have the status of the other ROCK inhibitors. We have narcisudyl, which is in phase 3 trial, and we have AMA0076, which actually is in a phase 2 trial. And then we have verosudyl, which was discontinued, and of course the ANS115644, which is in, again, a phase 1 trial. So if you look at the N-methyl D-aspartate receptors, the antagonists. So they block the pathological rise in glutamate, which is actually neuroprotective, and memantine actually did not meet the primary endpoints, so that was not successful, and all other antagonists are actually failing in glaucoma trials. So to look at neuroprotective agents, we need ciliary neuroprotective factor supplementation. This phase 1 is neurotropic factors for retinal ganglion cell and exogenesis factor. So the direct neurotropic agents, that is the brain-derived neurotropic factor, the nerve growth factor, and the neurotropins themselves. And next we have the gene therapy. So in the gene therapy, the target tissue is the trabecular meshwork, which has these particular DNRHO gene or C3 or DNRK or CSDS genes, and they actually target the trabecular meshwork. They cause a disruption of the cellular additions that are there between the cultured cells. Then we have drugs which target the ciliary meshwork, that is the PG kinase, and which increases the MMP's expression. And then you have those which target the retina, and that also has a host of drugs which actually can cause RGC survival. So it's a message to the industry that you actually need to do research on these drugs to be make them available maybe by the end of this decade at least. So the upcoming newer modalities, the pipeline for the development of glaucoma drugs is very rich. So you have the STAT3 activation, and then you have the erythropoietin and the INOS2 inhibitors, and what we were talking in the morning about the caspase inhibitors. So let us think beyond lowering intraocular pressure. What are the other factors that we can actually target in a glaucoma patient? And then we have the need for newer drug delivery systems, which will reduce the dosing frequency, improve adherence, ensure proper application of the drug, increased bioavailability, and adequate delivery of the drug to the target site. So let us drop the drops altogether and move on to other methods. Of course, the surgical implant is something which is invasive and maybe not applicable for everybody, but then you have the punctal plugs which can be inserted into the puncture that elute the drug, and then you have liposomes, that's aqueous core enclosed by the phospholipid layer, and the status of the liposome Latanoprost, which is actually in trial, phase 2 multicentric trials. It's going on, so hopefully that would come in soon. And then you have the nanoparticles, which have better drug penetration at the target site and have an absolute prolonged action of the drug. Next, you have the contact lens delivery systems, and the advantages: deliver the drug over a long period of time, but the limitations are, of course, you need to wear the lens and it needs to remain in a hydrated state. Then you have the microelectromechanical system, the reservoir in the subconjunctival space, and finally, the limitations of these newer drugs. Long-term safety needs to be studied. So again, we need studies there, clinical trials with these new delivery systems, so that we can come to a conclusion that we can actually use them in practice. And to look at the summary, we had beta blockers decreasing the aqueous humor production. Then we had myotics increasing conventional outflow. Then we had prostaglandin analogs which increase the uveoscleral outflow. So just to summarize the whole thing, PGAs still remain the first line for primary open-angle glaucoma, and followed by beta blockers. And myotics, hyperosmotic agents remain the first line in angle closure glaucoma. In clinical emergency, laser procedures are always preferred over surgical procedures. Pharmacological agents for neuroprotection under development, they should come in soon. And then you have the newer methods of drug delivery system. This is a slide which did interest me because it has the vegetations which are there. Ginkgo biloba has actually been on a very long-term study, and yet we have no results. And of course, cannabinoids have not been approved for ophthalmic use. So to stop apoptosis, what we need is today's commonly used glaucoma medications were approved in the 1970s. So other medications with different chemical compounds followed. Until now, there has been no major medical breakthrough since 1998. We need to have some better options in the form of direct neuroprotective agents for patients whose needs are not being met with. The medications we have had until now being great. That is definitely a big compliment to the industry. We have a host of glaucoma drugs that we can choose from, a cafeteria choice, a wave of new insights into the causes of glaucoma therapies is the need of the hour, and the development of these new medications combined with the explosion in the surgical arena with microinvasive glaucoma surgery will signal a renaissance actually in the field of glaucoma. And researchers, doctors, and of course their patients and the industry can then call it the prime time in glaucoma. So let us together stop cell death, and we need to get beyond ocular pressure lowering medications to neuroprotective drugs. Thank you for your